Hi, my name is Denise Albright. I'm a program manager with the Prevention of Youth Initiatives within the Prince George's County Health Department. Thank you.
And just so everyone knows, I went ahead and started the meeting recording. So if anyone wants to turn their video off or just comment throughout the meeting, do so as you feel comfortable. But thank you again, everyone, for joining us. If I haven't met you yet, my name is Taylor Palmer, and I'm a health policy analyst here at the Prince George's County Health Department. I help manage the Behavioral Health Advisory Group and our other work groups, as well as our Local Health Improvement Coalition.
And I'm Margaret Fowler, the Executive Director of Totally Linking Care in Maryland, and as a co-director or co-chair of this group.
Hi, everyone. I'm Faith Adeboye. I'm the Program Director at Dyer Crisis Center.
All right, well, we will go ahead and get started. We have an activity for everyone to do while we wait on a few folks. So thank you again, everyone, for joining the September Behavioral Health Advisory Group meeting. We are so glad that you are here and hope everyone is doing well. So as everyone has already started, if there's anyone new joining us this afternoon, if you haven't introduced yourself, if you'd like to come off of mute and introduce yourself or use the chat to introduce yourself, please let us know your name and your organization. And while we work on that, for those who were able to attend the coalition meeting last Tuesday, our quarterly meeting, we are in the season of rebranding. We are renaming the coalition to represent all of the efforts from all of our partners. So over the course of the past two quarterly meetings, we have asked members of the coalition to submit name ideas and principles that are crucial to the coalition and what the coalition represents. And so the coalition has narrowed it down to 3 name choices. We are asking everyone, if you have your mobile device handy, if you wouldn't mind scanning the QR code, and you'll be able to vote on your top name choice. We've narrowed it down to 3 name choices, and we're asking everyone to vote on their top name choice. And I'll put this announcement up at the end for those who aren't on the call yet, but our voting will end Monday, September 30th. And I can also put a link in the chat for folks. We will give folks just another minute to submit their responses, and then we will get to today's agenda. All right. Well, thank you everyone for casting your vote. If you are looking around our virtual meeting space today and you're not seeing folks who are usually present, if you wouldn't mind sending that link out to folks. Again, voting will close Monday, September 30th. I'll include the link again in the meeting notes as well as our newsletter. So you'll see it a few more times. And again, just feel free to share it with your networks. And come October 1st, we will hopefully have a new coalition name. So getting to our meeting today, we will first open with a presentation from the Dyer Crisis Care Center. We'll open it up for some Q&A time. Then we'll move into an interactive activity, including the discussion of the Prince George's County 2025 Community Health Assessment and talking through some of those data indicators to comprehensively tell the community's story and thinking through the prioritization process that'll happen as the health department undergoes the 2025 CHA cycle. And then, as usual, we will open it up for community announcements and upcoming events, and then we will adjourn for the afternoon.
Okay, well, I would like to thank Faith, and I saw Alicia also is on from the Dyer Care Center. I have been able to see firsthand the wonderful work they're doing there, and we wanted to share with the rest of you all the work that they're doing. They opened on September 5th, and the very first day, I just saw such an amazing change in how guests are arrived, how they handle them, and just the wonderful outcome that they've been able to do in such, even though they just opened in September. So I'd like to turn it over to the RI team. And Faith is the program director. And Faith, I'm going to let you pronounce your last name. But I want to just say thank you for the RI team coming today and doing the presentation. So I'll turn it over to Faith.
Hello, everyone. So I'm glad to be here. I just wanted to say real quick that this is more of a chance to talk through and answer any questions that you have for Dyer. I could do all the introductions, but I know that there might be things that are specific to how we operate that you have questions about. And I'd like to be able to answer those questions. I have Alicia here. She's our Vice President of Clinical Operations for Recovery Innovations, and they're the program operators for Dyer Crisis Center. And she might be able to add more later on to what I share. But you can introduce yourself, Alicia.
Well, I don't want to turn my speaker on because then we're in the same room, but nice to see you all. And I will also questions after Faith's presentation.
All righty. So we are part of the crisis continuum with the Prince George's County. And as of right now, the framework for the crisis continuum has different components to it. And the easiest way to just break it down is if someone is experiencing mental health or behavioral health emergency crisis or substance abuse emergency crisis, and they need a place to go to for crisis stabilization and emergency services, then we will be the place for them to come to. It's important to be able to know that we are a short-term facility, short-term in terms of the fact that guests are with us for up to 24 hours. And during that time, they're going through observation, crisis stabilization within a home-like setting. Our setting looks like a living room, open space where they can be seen by all the staff at all times. They are getting assessed by a multidisciplinary team. So the assessment is done by a clinician. They're getting assessed by nursing. We have psych evals by our providers. And they're also in a setting where they get to interact with peer. We have a peer power model, and I'm going to go over some of our essential principles and practices a little bit later on. But within that 24 hours, it's basically ensuring that anyone, regardless of how they come in, is able to get the services they need. So we have a no wrong door policy, which means that a guest can come in voluntarily. They can walk in, be dropped off by family, or they can come in through, law enforcement, involuntary admission, emergency petition, or otherwise. Regardless of how the person comes in, we will not turn anyone away because we want to offer a safe and supporting environment for them to kind of start the journey towards recovery. Excuse me. Whenever a guest comes in here, from the moment they come in, we're thinking about where they're going. Because we're short term, we have to essentially get enough information, get them assessed so that we can start to make the determination about their next level of care. If they're going inpatient, if they're going outpatient. But the key to the RI model and the crisis stabilization model that we have is to divert as much as possible people from the hospitals. So diversion for us means that we're reducing the amount of people who are going to the emergency room. We're also trying to ensure that those who don't need to be hospitalized don't get hospitalized. So there are challenges with getting people into the emergency room. And for those of us who are providers on this call, you probably know better than other people how challenging it can be for someone who's in a crisis to have to sit in the emergency room for hours and hours, waiting to be seen, waiting to be assessed, medically cleared, and then transferred to the inpatient unit. By the time they get into the inpatient unit, they are, sometimes they're already traumatized and don't want to be there. So the treatment they get there might not even be effective as effective as it could be if they were in a different type of environment. So we are there to bridge that gap and to ensure that only those who need to be hospitalized get hospitalized. But anyone who does not need to be hospitalized is getting the care that they need. We also want to divert from potential incarceration because there are people who unfortunately get in unpleasant situations with the police because of their behavioral health diagnosis or substance use disorders. And right now, they either go to the emergency room or they're taken to Department of Corrections. And they really do not need to be there because they're only acting out based on their history or their diagnosis. So that's why, we are a diversion program, because the stabilization and the work that we do with them helps us to be able to make sure that the next step for them is treatment. And that's, whatever is available within the community. Also, we partner with other services like 988, with mobile response team, and also everyone on the continuum for the county. And the continuum is made up of different components. I'm not going to go into that. But for us specifically, we're 24/7, 365 days a year program operated by Recovery Innovations. We are adult only. So the guests that we work with here are only 18 and older. We also see both insured and uninsured individuals because we have funding to be able to provide those services for those who are not insured. Before I go further into our principles and practice, does anyone have any questions? Okay.
Oh, yes, I do have a
Okay.
question. I'm
Right.
sorry.
Mhm.
Can you hear me?
Yes.
Oh, yes, I was just wondering, no, thank you so much for, offering this service. I mean, could you just help me understand, like, how a clinician would decide whether to refer someone to your service versus mobile crisis versus the emergency room? Because I know maybe sometimes a clinician might feel the person really needs to be hospitalized. That's the safest, um, you know, venue for them. But how do you look at your service versus mobile crisis or referring someone to an emergency room for hospitalization?
So the essential difference between mobile crisis and us is the location of service. So with mobile crisis, they will go to the person, they will go to their homes, they'll meet them in the community. They have their team, they're going to get the assessment done. And once they get the assessment done, then they will transfer to whatever the next level of care will be. Now, though, mobile crisis has one more place they can take people to, aside from just taking everyone straight to the hospital if they believe that the person needs stabilization. So even though mobile crisis does the assessments and other things like we would, they essentially are in the community and they will not provide the service for that person, the stabilization for that person. They can come assess to see if the person needs to go to a higher level of care or to a different type of care, but we are a place to go to. So for someone who's trying to decide, okay, this person, I'm not sure that they're a risk. Well, let me put it this way. They are not to the point where they need to be in a 3-day, 5-day facility. They just need a place where they get assessed and somebody can put them with the right care. Then Dyer will be a place for them to come to. And with our with the guests, like I said, there's no wrong door, so they can come in themselves. They can be brought in by their clinician or whoever it is that feels like they need to come with them. They can even be brought here by police, even if they're voluntary. But we are a place they can stay. They can be observed. And not everyone has the level of escalation that will require for them to be in the hospital for 3, 4, 5 days or even more. Sometimes just the short-term stabilization is sufficient to have someone back in the community.
Oh, and may I also ask, your decision to only see people 18 and over, is there a reason that you don't see adolescents or?
No, there's not a few reasons. The only reason is that our company, we don't serve adolescents. So just across, we're in multiple states, and so we don't currently see any adolescents in any of our states.
Great, thank you so much.
So with regards to that, thank you, Larry, for the question. With regards to the services that we provide, we are recovery oriented. So all of what we do is geared towards helping people on their recovery journey. When it comes to mental health services, it should be geared towards healing. It should be geared towards the well-being of the individuals and also focusing on their strength and their resilience. Even when someone is presenting in a crisis, a lot of times it's because they've depleted the resources that they believe that they have, or just those coping mechanisms just aren't working in the moment. It doesn't mean that the person doesn't have this, the wherewithal to be able to manage their symptoms, but it could be that they just had days without sleep, or they've not had their medication. They're out of medication for a few days, or they had a sudden stressor show up in their life. But that doesn't mean that that person isn't able to still be a human and still be able to function in the community. They're just having a rough, sometimes the worst day of their lives. And we tell our staff all the time, when people are in crisis, we don't determine the crisis, they do. So a crisis for me might not be a crisis for somebody else. And I don't get to tell you whether you're in crisis or not. So for a lot of the people who will walk through our doors or be brought in, we try to meet them where they are and see, okay, what step in the journey are they? Are they already connected to care? And we just need to make sure that they make it to their next appointment and continue on the path that has worked for them. And they just had a break. Or do we need to find new providers or new connection to care for them? So recovery orientation isn't just putting someone into a box because of their crisis, but ensuring that we see the holistic view of who the person is, and then make sure that we do our jobs in managing their symptoms as much as possible. And then the other principle is the trauma-informed care. When it comes to mental health professionals, we're equipped to recognize the effects of trauma. It can be very far-reaching. A lot of people have experienced trauma themselves, and so when they're in crisis, a lot of times because there's a trigger or something that is bringing up that trauma, or they're self-medicating with drugs, or they're trying to cope with the terrible things they've experienced. So a trauma-informed care also means that we're understanding and compassionate and empathetic towards the things that could be leading to the crisis in the first place. And we're also integrating the knowledge that we have, the training that our staff has in managing all aspects of their care. And then the peer-powered approach. Peers are people who themselves have lived experience with mental illness or substance abuse, have been in recovery themselves for at least 2 years and are doing well and wanting to give back to the community. And a lot of times we forget to humanize mental illness, because there are people who have recovered and are doing well after a crisis. They themselves have been in the hospital multiple times. They've been in the lowest points of their lives. They've had the worst day of their lives, and they've been there, done that. They've come out on the other side of it. And so a peer-powered approach allows for us to be able to utilize this peer staff to engage the people who come through our doors, engage them and help them navigate similar challenges that may have been faced, also giving them some insight or support as needed, so that they can see that they can also get on that path to recovery. They can also make something out of their lives, and this day does not define the rest of their future. We also are committed to the zero suicide and suicide safe care. And a lot of times when people are in crisis, one of the ways that we can also determine that is if there's an imminent risk to self and others. So through our facilities, we're ensuring that we provide a way to protect people from hurting themselves, from hurting other people. And this is also a chance for them to also, calm down from whatever heightened state they may be that could lead them to hurting themselves, and giving them a chance to be able to see other options and alternatives that might be open to them, as opposed to just one way. Does anyone have any questions? Because I'm just about to go over the last one, but that might be. And one of the other principles is our commitment with working with law enforcement, because a huge part of the involuntary commitment, as well as the people who are brought into a lot of our facilities, are, the people who bring a lot of our guests are public safety officers. They are there in the community. They're seeing these people at their worst, sometimes interacting with them. They're the ones people are calling if a neighbor is irate or aggressive. And so working with them safely is very important, not just to ensure the safety of the guests, but to ensure the safety of the community. So working with law enforcement is very important for us. And so we even have dedicated entrance for our first responders. So when they bring a guest, they have their own specific entrance, because we want them back in the community as quickly as possible. So holding them down for 3, 4, 5 hours like they would if they went to the emergency room is taking them away from public safety duties. But at our site, we've been able to get them in and out of here in an average of 4 minutes, less than 5 minutes, which is great for them, because that way they can spend the rest of their time doing other things. But they also can be assured that they have brought someone to a place where they can get the help they need. All right. Those are the things that I, cover, but I can elaborate more with more questions.
I think Alicia had a question.
Hey, Alicia. Good to
Yes,
see you
hey,
again.
good to see you. Yes, good to see you. Nice to see my old colleague Larry too. So what's been the response so far with filling your chairs in the living room? Have you been full yet, or?
We had a couple days there where we were getting a lot of people in here into the building. We have had to put a hold to involuntary commitments for right now. Just working out some things, and those details are, we're at the point where we're about to get more clarity, and then we'll be able to readmit we'll be able to admit involuntary commitment. But for right now, we are only having voluntary intakes. But when we did have all of the doors open, we were getting people in the doors, and sheriff's office, police office, as well as walk-ins from families. So we have had engagement. We're just right now putting a pause to involuntary commitment.
Okay, awesome. Thank you.
You're welcome. Anya.
Good afternoon, everybody. Thank you so very much. This is very useful. I was wondering if you can tell what percentage of your clients are first responder drop-offs versus regular walk-ins. That's the first question. And the second question is my understanding that this is the first crisis stabilization center in the whole state. So we're very excited and thrilled to have you in Prince George's County, very much needed. But since you are the first, are you being formally evaluated? Because I'm hoping that as we can see how you make a difference, that this may trigger additional investments and expansion of this type of much needed services. Thank you so much.
Thank you. So percentage-wise, even though we have paused involuntary, we still had more people come in through law enforcement overall. And so I would say right now, 2/3 of the people who have walked in our doors are from public safety, and the other 1/3 are, voluntary guests. And in terms of evaluation, yes, we are being evaluated. Oh, absolutely. Being the first also means that everything we do has to, so we are a site that is now with Prince George's County on the establishing a crisis continuum. I think they're the first county who is following the SAMHSA model for crisis now. So with that model now fully being implemented in the Prince George's County area, that hopefully is something that other counties are looking to implement within their spaces as well. So that's going to mean that there will be people who would want something similar to what Prince George's County has. So Prince George's County is already ahead with regards to that. And I will not be surprised if other programs, come up later on within the state. So someone asked in the chat, what's the maximum number of guests? So we have a 16-chair facility. So we have capacity for 16 at a time. Now we are a 24-hour facility. So that means that there's, quick turnaround. Within 24 hours, we're going to be discharging people. So those 16 chairs won't be filled like all the time. We would have space for ongoing admissions every day. Samantha?
Yes, thank you so much for this presentation. And I'm sorry if this is a bit of a beginner question, but I'm wondering if there's a role for like medically supervised withdrawal or stabilization for folks who are intoxicated, or if I'm not sure if that would meet crisis standards or not, but just curious what that is.
So our facility does begin the detox protocol for any guest who needs it. We do have people who are in active withdrawal or detox when they do come in. So that's why we have nursing staff. We have a full medical team to be able to assess and get them started on protocols needed for them to start like the stabilization can't happen if we don't start the protocols. We can't have them, going through all of those symptoms without the support that they need to be able to feel much better, right? So we have a full we also have a medication room that's able to like support any type of like medical intervention that needs to be done if someone is in withdrawal or detox. Any other questions? So I do have an ask, and if that's okay, Taylor, if I can. So we are definitely trying to connect with as many people in the community as we can, especially providers, because we have different people coming through our doors. The needs are very diverse in terms of like connecting to care. I know have been people we've reached out to using our provider list, but if there is any specific thing you do or your program does that will be important for us to know, please feel free to reach out to me or um, basically anyone on the Dyer team, or you can come by our facility and talk to someone, because we would love to connect with providers and build a relationship that allows for us to refer to you or for you to refer to us.
Faith, can you put your contact information in the chat?
Sure.
And is there any content? I know you mentioned you guys are on a hold right now, but is there any materials that you would like folks on the call to share, or is there any way the BHAG can continue to support you?
We have a website that I can share on here as well. And most of the time, anyone can call our main lines and ask questions. Any one of our team members will be able to, answer. I'm going to put our main phone number. And sometimes you might even want to ask, oh, is this person appropriate for your facility? I have someone in my lobby or in my office who's going through this. Can I send them down to you? So it's always good for us to be able to like have some, way for everyone to be able to communicate. So our main line is there, and our website is also in the chat. I'm going to put that in there. It's Dyer Care Center. .org.
Great. Well, thank you so much. Are there any other reactions or any other questions from anyone? Anya?
Sorry, that was by mistake. I apologize.
I just wanted to add a little bit to what Faith had said, and I think I hope people caught too is that how they refer to individuals that come to their facility, their guests. So it goes along with the whole theme of being a relaxed, like living room environment. So I also can share that this is part of the Totally Linking Care grant through the HSCRC. There are one-pagers that we've developed for education purposes that the Dyer Care Center has, as well as a brochure that explains the crisis continuum, someone to call, someone to come to you, and somewhere to go. We have all those numbers with a brief explanation if you all would like some of those things to be at your organizations. If you let Faith know, I think Faith, you have a lot of those, but if you can
I
be
have one right here. I have 20 in my office.
Yeah.
If you need like some one-pagers for your office or something, I can definitely have some available for you.
Yeah, and what we can do too is we can send out an electronic version of the trifold that explains the crisis continuum. So that way, sometimes we're trying to make sure that the community knows, instead of, like Larry, you had initiated, like, how do providers know where to go? And so we want the community to know that as well. So we're going to be providing that in our hospitals, as well as we would want a lot of the community providers and organizations to have them available so that the residents of Prince George's County can utilize a crisis continuum how they see that they need it most.
Hi, this is Nina Ward. I am joining by phone because I'm just leaving the Criminal Justice Coordinating Council, and wanted to say there was an extremely positive reaction from our law enforcement partners in working with Dyer in its first opening days, and a thirst for more information. So definitely want to distribute the materials that you're talking about, Margaret, with the court system and with additional law enforcement partners. But thank you, Faith, for your presentation and all the work you've done. You've made an amazing impression on the Sheriff's Office and our partners in the criminal justice system.
Thank you.
Oh, Faith, I just wanted to ask one other question. I know you guys sort of were answering this, but I was just wondering, what you're offering is such a valuable service. Help me, is there a regulatory or clinical reason why your service can't be offered to adolescents? I mean, why isn't a service like yours available to, kids in, the school system or
Faith, I can take that one for you.
Margaret, go ahead.
Larry, I think because when this is part of the HSCRC Behavioral Health Catalyst Grant, and this was implemented probably like it started about 3 years ago, and it was set up to only do adolescents at the time. So because the regulations for having an adolescent and adult unit, they cannot be together. There's regulations, as you know, that are specific to child and adolescent stabilization centers versus just adults. So the facility at which Dyer Care was placed, the manner in which it was initiated would not permit it to be extended to the adolescent and child restrictions that were required by the Maryland regulations. We were trying to look at that, but it just was not able to be done at that location and at the level at which the Dyer Care Center had already begun implementation.
Oh, well, no, thank you. And that makes sense. I mean, I was just wondering, would the county ever, consider an adolescent stabilization center? Because I know with my involvement with Montgomery County, I mean, they don't exactly have what Dyer's offering, but I know their crisis center gets like 1,500 referrals a year of youth from the county school system. So I know there's a big need for it, but it's just interesting to me um, if there's any plans for any, going lower in the age at some point.
I think there is, Larry, but I can't speak to the specifics, but I can tell you there is discussions about that happening in Prince George's County. And that would probably be more with, the health department and the local behavioral health authority.
Great. Thank you so much.
Mhm.
And I just put in the chat here the resources from TLC that is on the website regarding the crisis continuum and more material on the Dyer Care Center. Faith and Margaret, are there any other materials that we can share with folks now or include in the notes?
What I'll have to do is I'll have to go and pull the electronic version of the trifold that we have and the education piece on the continuum that's currently being used. I can get those to you and then they could be sent out with this meeting and if people want copies of them, they can just let us know. We could try to get, copies made for them.
Thank you very much. Any additional questions or next steps? All right. Well, thank you again, Faith, for joining us this afternoon and talking about all of the great work that's going on over at Dyer. We really appreciate your time, and please do continue to let us know how we can support you all.
Thank you.
All right. I am going to switch us over here back to our meeting slides. All right, so in our remaining time this afternoon, I just wanted to give a really quick overview for those who were unable to attend our coalition meeting last Tuesday night. We discussed the health department's next steps regarding the community health assessment. So the health department is moving forward in the 2025 CHA cycle. And so that is going to include quantitative and qualitative data collection. So we wanted to touch base with everyone, and we wanted to bring this to everyone's attention as the content experts to take a look at the areas that the CHA has previously focused in. So for this work group, that includes behavioral health and substance use, and to take a look at the indicators that we have previously been tracking, to look at the health outcomes in Prince George's County, and take a look at what is missing and what do we need to take a closer look at. And so we have an interactive activity for everyone to participate in. It'll be quick, but again, we just wanted to bring a conversation up regarding the data indicators that the health department is currently tracking to tell the most comprehensive community story that we can. We want to be able to tell about the disparities and the gaps and the areas for improvement, while also giving note to some of the strengths in the community and all of the abundant resources that we have here, all of you included on this call, and where we need to go to move this thing forward. So before I do that, I wanted to give a quick overview of the State Health Improvement Plan. So this came from the Maryland Department of Health. I will send out with the meeting notes the longer State Health Improvement Plan for those who are interested. So the state has named 5 leading health priorities that they are moving forward with, one of which is behavioral health. And so under that umbrella is efforts to expand access to and the utilization of behavioral health services, reduce disparities in mental health outcomes, reduce overdose and negative health outcomes associated with substance use. And so in order to track this goal, they are measuring the following indicators. They include the emergency department visits for mental health conditions, rate of suicides, youth substance use disorder providers, utilization of public behavioral health services, students who felt sad or hopeless most days for more than 2 weeks in the past 2 weeks, and for all students and LGBTQIA+ students, availability of affordable housing as a determinant for mental health, opioid fatality, emergency department visits related to addictions-related conditions. And so our ask for the work group today, we're going to compare these state indicators to what we've previously used with the 2022 Community Health Assessment. And we're going to ask you all, what are we missing in our data tracking? What should we include? What are some data sources that your organization is tracking that you've previously used? And what can we think about in telling the community's story in this health assessment? And so again, we're focusing on the quantitative piece, but we'll also have that qualitative piece where we bring in the lived experiences of community partners, community residents, to tell the story in the community health assessment. Does anyone have any initial reactions or any questions?
I have a question. Shatia, nice to see you. I see the utilization of public behavioral health services. I wonder if the state is concerned at all about the private industry in terms of at least the number of private providers, or it may be very difficult to measure the utilization, but maybe not. But just, is there an interest in terms of how the private providers are contributing to the data and the health priorities? So that's one. And then also quality of life measures. I think it's important to measure overall quality of life as we are thinking about the behavioral health outcomes, just because we understand that just because you may have
a mental health disorder. It doesn't mean that, you know, there's some interaction between well-being and ill-being. And I think that there's some space to begin to explore quality of life, which encompasses both of those phenomena, or yeah, those independent phenomena.
Yes, thank you for that. And we'll move into the interactive activity where we'll talk more about those quality of life measures. But to your first point, we are working on having a presentation from the state regarding the state health improvement plan. And so that's something that we can bring up and ask about in that meeting. And also talking about the partners and the providers specifically. These are in the state health improvement plan and their process. They put out a survey, a partner survey, and a community input survey about the leading health priorities in Prince George's County. So I did just want to put this up just to give folks some context as to some of the responses that they collect in terms of Prince George's County. And again, we'll go into that deeper if we're able to have a call with MDH to talk through more about the state health improvement plan. But as you can see, mental health, and then a lot of what you were just describing, Dr. Blunt, here with the social determinants of health were named as critical things that make a community healthy, and trying to ensure that we are moving forward to get our health in this very good and excellent category. So moving this moving this pie chart more. Any other reactions or questions?
Yeah, Taylor, I think the one thing that seems to be forgotten sometimes is the prevention is, you know, and how do we prevent, you know, our youth from going down this path, or how do we help them before they get into you know, coping skills and things like that. So, and I know that we had talked about a mental health wellness annual checkup, those kinds of things, that I think that's a piece that should be added as well.
And just to add on to that, I will be advocating again this year for the annual behavioral health visit. And at the end, I hope to have a moment, Taylor, if possible, to talk about another legislative idea that I am advocating for.
Absolutely. Please do keep us posted. So let me move us into the interactive portion of this, so folks can add their feedback, like you just said, Margaret, there with the tracking the annual wellness checks. Folks, if you are able to scan the QR code, this will take you to a short survey. We'll just do one question today to get your feedback on. But if you would like to use the website, you can go to slido.com and you'll just put in this 7-digit code. The code is 6467673. Is anyone having any challenges joining the Slido? Well, here is the question that we hope folks can respond to. So on the left-hand side here, you'll see we have an image, and we have 2 tables. So the first half is the table from the 2022 Prince George's County Community Health Assessment. So this is what we previously tracked in the 2022 CHA. And so as you can see, we break it down by the indicator and those measures. And then also what you previously saw in the last slide that I shared, those state health improvement plan, the indicators that they are tracking. So like Dr. Blunt had mentioned, and Margaret as well, what are some indicators that we are missing, or what are some data sources that could be included to better assess substance use and behavioral health?
Hi, Taylor. This is Denise. While folks are responding, I had a quick question. The results of the survey, the interactive activity that you're doing, and I'm glad that the state has identified mental health and behavioral health as one of the metric or the variables that they're interested in. Um, I have a recommendation that whatever the result is and the new metrics or areas that have been identified, if we can also use that to update, improve, I guess you will, or add those metrics to data sources on PGC Zone. Because right now on PGC Zone, the behavioral health, mental health data pieces are sparse. There are a lot of health variables, surveillance data you can get there, but as a place that we're trying to build for as a data repository, I think building out some more data pieces will be good. YRBS, to have those included, and just more data as it relates to substance use as well.
Thank you, Denise. So far, we have some responses here for addressing, again, relating back to the public practice utilization and providers, but also considering private practice providers and utilization rates, the quality of life measures, drug and alcohol intoxication death, understanding behavioral health outcomes. Good afternoon, Ms. Cheryl. Thank you for joining us. We're continuing the discussion from the coalition meeting. So if you have any additional thoughts, the question to the group is, what other indicators and data sources could be included to better assess substance use and behavioral health? So we had a discussion about looking through to see understanding behavioral health outcomes data by smaller geographical units. So possibly taking a look at zip codes, drug and alcohol intoxication death by hospital emergency medical services. And then the state, they are measuring public practice utilization. And so there is an opportunity to also focus on private practice providers and utilization. So if you have anything that you'd like to add, feel free, you can say it out and I can add it, or you can scan that QR code and join. And for the answer here, the surveys of feedback from providers, can someone elaborate on that and what we would want to include in those surveys?
I'm the person who put that. I am on mute because I'm in a noisier background, so I can't talk for a long time. But I was just thinking about how you begin to access people who have private treatment. I mean, I think it's easier with Medicaid, but with private insurance, it may be more difficult. So I was thinking about anonymously surveying their providers around their treatment and treatment outcomes as another way of getting at the data. And I don't know how you would do it. I hadn't thought about it that far.
Thank you for that. And we didn't include it on this slide, but are there any measures specifically if we're looking at age groups? So I know, Larry, you talked a lot about adolescent mental health today. Are there indicators that we're missing for adolescents, for aging adults? Measuring mental health issues occurring with chronic pain. Ms. Cheryl?
I'm thinking also, this may be a small sector, but what about the partners, including my own organization, in terms of indicators, in that we could inform to some extent what it is in the way of indicators that we believe we are seeing and can provide the data for.
Yes, please. This is that was our purpose. You hit the nail right on the head. If you have anything you'd like to add now, or we can schedule a call.
What about dementia? I know you talked about elderly. I didn't really see anything in here about dementia.
Yes, that is an indicator. We have it in another okay. slide under our aging populations. Yes.
Okay.
All right. Well, any other thoughts? And this will be a continuous process, and we'll continue to share out where we're at in the process. And of course, community engagement and our partnerships is an integral piece of the community health assessment. So we will keep everyone informed and ask for your participation throughout the process. But I thank you all for giving your input today. And certainly, if you think of anything after the meeting, please feel free to follow up. If anyone is interested, we're going to go further into these topics, these data topics, in tomorrow's health equity work group meeting. So these are the other topics. Margaret, this is what you were getting at a little bit with our caring for aging populations. We're going to take a deeper dive and look at with those folks in that work group meeting, taking a look at how we tell the community story through a health equity lens, make sure that we are following indicators that could get at some health disparities in some of these areas, and continue the discussion. So if you are interested in discussing more about the data measures, again, the health equity work group is meeting tomorrow at 3 p.m. and I will send out information to be able to join that work group meeting for those who are interested. All right, and to close us out, we have a few community announcements. So first, coming up this weekend, Saturday, September 21st, is the Mental Health Symposium. It is occurring at the Reed Temple Church. It starts at 10 a.m. And I will include the registration link in the chat for those who are interested. And next, we have an exciting announcement about the Black Mamas Matter study.
Oh, yeah, I can go. Hi, my name is Asohe. I'm a student at the University of Maryland College Park, and I'm here representing my honors program, which is a research program, Team Black Mamas Matter. So we're currently looking at factors that impact the Black maternal death rate in Prince George's County specifically, and we're particularly looking into patient-provider interactions and seeing how provider curriculum during medical school and during their formal training impacts how they interact with patients. So in order to get more information about that, we are surveying two groups. So we're looking at mothers and medical providers. So medical providers can be doulas, they can be OBGYNs, really anybody that is impacting mothers during their pregnancy journey. So I'm here asking for your help in disseminating this survey out to people because we're trying to get a very representative sample. So this is something that we can share out at future health equity work group meetings, future coalition meetings, and also to the Prince George's County Health Department. If anyone has any questions, you can either email the email on the flyer or you can ask them now. But yeah, thank you.
And I will send out these flyers with the meeting notes, but are there any questions or any reactions? Okay, well, thank you for that update. And then last, for those who were late joining us today, again, we are renaming the coalition. So if you all would like to vote for a new coalition name, you can either scan the QR code or I also put a link in the chat. The voting will close on Monday, September 30th for the new coalition name. And next, MedStar Southern Maryland Hospital, they're hosting a senior health and wellness fair on November 23rd from 10 a.m. to 2 p.m. I put in some contact information in the chat for any organization who is interested in participating in the event. You can email Jessica, and I will be sure to include that in our meeting notes as well. Next, from our partners at Change the Conversation, there are upcoming fall training opportunities. The Conversations for Change, they are launching several new clinical trainings, specifically for clinicians and mental health providers that work with those impacted by child sexual abuse and trauma. And so to register for those upcoming events, as you see here, several coming up next week and all throughout the last quarter. And if you would like to register for those trainings, please visit the link in the chat. And lastly, as we continue to talk about all of the resources in Prince George's County, we want to make sure that we're increasing awareness and we are breaking silos. And so to do so, we have the Community Care Coordination Team. They are a fellow work group within the coalition. They are meeting next Thursday, September 26th at 11 a.m. During that meeting, they'll go over a little bit more about a community resource inventory that we use here in Prince George's County called Find Help. In Find Help, organizations are able to input information about their programs and their organization. It is a care coordination effort to be able to link folks to resources. A lot of our community health workers use Find Help to get folks in the community aware of all the different resources in Prince George's County in an array of topics. So behavioral health for those experiencing housing insecurity, food insecurity. So we encourage everyone to join that meeting. Next Thursday, we'll actually be going through Find Help to take a look at the organizations that have already claimed their information in Find Help and see who is missing, so we can build a more comprehensive resource inventory. And Ms. Cheryl, I see your hand.
I was wondering, while looking at Find Help, I would want them to have information about our organization, the Black Mental Health Alliance, because we're a part of the Prince George's County Health Action Coalition. Do they automatically have access to those comprising the coalition, or do we have to contact each individual organization, such as Find Help, to give them that information?
That is a good question. I will follow up with Find Help to see what information they need. But we could get them the information that we have from all of our partners within the coalition and see. I do believe that a person from the organization actually has to take ownership of the profile. So I think that would require the partners to be involved. But I can get more answers. But if you are available next Thursday, please join us, or you can send me information about your organization and I can see about getting that added. Thank you. All right. And are there any other community announcements or any upcoming events from any of our partners on the call?
Hi, I have a policy advocacy, I guess, message. I am this legislative season, we are preparing for the third year of advocacy for the annual behavioral health visit. And so if anyone is interested in joining that advocacy effort, please feel free to contact me. I'll put my email in the chat along with my website, new website. I'm very happy about it, that has a page dedicated to this policy advocacy effort. And in addition to that, I have a meeting later next month with Senator Malcolm Augustine to discuss another policy initiative where to address the behavioral health provider shortage. I understand that new graduate level clinicians can only service the recipients of public insurance if they are employed in outpatient mental health clinics, which leaves folks from being able to work directly with me, like in private practice, and get, said supervision and be able to service folks in that population. So I am proposing having a meeting with the senator to seek his sponsorship on a new bill that expands the pathways, I guess, in which LMSW therapists can service the community, specifically those having public insurance. So if you are interested in learning more about that idea, or possibly attending that meeting in support, or wanting me to pass a message along that you may want to support, please feel free to contact me. And so I'll put my information in the chat now.
Thank you, and keep us posted and let me know when you are ready to present more information and any updates you have. Any additional community announcements or upcoming events? All right, well, thank you everyone for your involvement today. We will reconvene as an advisory group next month on Wednesday, October 16th at our usual time from 3 to 4:15 p.m. If anyone has any announcements in the meantime, please feel free to give us an email or add your events to the calendar, and I will be sure to get out all of the meeting notes from today. But thank you again, and everyone take good care.
Thank you, Taylor. Thank you, everyone.
Thank you,
Thank you,
Taylor.
Nina.
Thanks, Taylor.